So it's my pleasure to introduce Dr. Howard Mang, who's a clinical assistant professor at the University of Toronto and works as an anesthesiologist at Sunnybrook Hospital, to introduce our next session and our speakers and moderate the next session. Thank you so much.
Thank you, and it's a pleasure to be here. I hope everybody's having a great morning. It's been a great learning opportunity for myself so far, and I'm very excited to introduce our next speaker, Dr. Yasmine Hoydonckx, a friend, a colleague. She's an associate professor at the University of Toronto, staff anesthesiologist and pain physician. She's obviously been introduced before, and without further ado, she will be speaking about epidural blood patch. Dr. Hoydonckx.
Okay, good morning, everybody, again. These are my conflict of interest. And I'd like to talk to you today about epidural blood patches. As you know, these are the first line of treatment against spontaneous intracranial hypotension. And what it basically entails is a procedure where autologous blood gets injected in the spinal epidural space, which is a potential tissue plane between the dura mater, which is surrounding the spinal cord, and the bony spinal column. That extends from C1 up to the sacrum. Posteriorly, the epidural space is filled with fat. Anteriorly, it's filled with nerves and blood vessels, and that has an importance when we talk a bit later about when we do the injection of the blood anteriorly or posteriorly. So epidural blood patches are mostly offered for type 1 and type 2 leaks, so the spinal dural tears or meningeal diverticulums, but also sometimes for CSF venous fistulas as well. The rationale of the epidural blood patch is twofold. As you know by now, patients present with orthostatic headaches and associated symptoms due to decreased CSF volume and pressure that creates downward sagging of the brain. Injecting a high volume of epidural blood in the epidural space, normalizes the loss of pressure and volume and improves symptoms. At the same time, the injected blood gives a cephalad displacement of CSF pressure from the leak side, so the leak can heal. And also, due to interaction of injected blood and the procoagulant components of CSF, it forms a seal over the defect, again, giving time to the dura to heal on itself. So, epidural blood patches can be performed without image guidance. It's a more classic approach amongst us anesthesiologists, or can be done under X-ray or CT guidance, which allows, in that case, for injection of contrast and confirmation that the blood is actually in the epidural space as well as spread. At the same time, we can also target the blood more to a certain level, which is not in the case with when we do a blind or a non-image guided approach. Usually, the standard first approach of an epidural blood patch is non-targeted. Okay, what does that mean? The patient presents with a leak. We don't have any certain specific details yet of the level of the leak, but we do have confirmation that there is one clinically or by having like a slack on an MRI spine, for example. So we start with a non-targeted blood patch that's usually done at the lumbar or thoracolumbar level, and usually we'll call for a high volume because, again, we don't know where the actual leak is located, but we want to target it as well. So we try to inject as much volume of blood as possible as the patient allows us to do, in hopes that it will cover the leak itself as well. So this one can be done non-image guidance or with image guidance at the same time. The other option is a targeted blood patch, and usually it happens further down the road when the patient has had more investigations and we have a clear idea of where the leak is located. So we can do a targeted blood patch really at the level or just below the level of where the leak is located, and really target the blood to cover the leak in that area. That will allow us to inject lower volumes of blood, and sometimes we also add fibrin glue to it. So intuitively, you would think that a targeted blood patch would be better. However, unfortunately, nowadays, there's no RCTs that have comparing this technique, and the best evidence we have is based on this systematic review on 144 papers, where there is, at that point, no significant difference between non-targeted and targeted, although, again, intuitively, we would say targeted would be better. In terms of approach, very important to understand this concept as well. So when we do a non-targeted blood patch or non-image guidance, we usually go for the interlaminar approach. So that means that we inject or insert our needle at the back end of the spine in the dorsal epidural space, and we inject the blood in that direction. So most of the blood will spread posteriorly in the epidural space, will also go lateral, and sometimes even anterior, okay? The other approach is transforaminal. So in that case, we actually place the needle through the foramen where the nerve exits, which is more in the anterior part of the spinal column, and this will allow for the blood to be directly injected more anteriorly, so in the anterior epidural space, and that's, of course, the preference when there's an anterior leak. For some levels, of course, when we go from thoracic or cervical, the transforaminal approach can be challenging. And so alternatively, you can still do an interlaminar approach, but where we basically, as Dr. Philip Peng always calls it, the curveball technique, where we basically try a paramedian approach and direct the blood that it flips around the spinal cord towards the anterior epidural space, and actually have very good anterior spread with this technique as well. The timing on the non-targeted epidural blood patch is very important, and we know now that it must be done the earlier to better, because it really improves our outcomes in the long run. So usually after 2 weeks of conservative treatment, you should be offering your patient to do a non-targeted blood patch, even if the patient is only clinically suggestive. And Dr. Carroll will talk a bit more about his recent paper there, but there are even patients that are clinically suggestive, but where imaging has not been able to show a leak yet, it would be recommended to just do a non-targeted blood patch to see the patient's outcome and result of that before you actually do more investigations. Usually when you would do like a repeat of the blood patch, we aim to wait 2 to 4 weeks, but of course we can make exceptions to that as well. And then as a physician who is doing these blood patches, of course, we want the best outcomes for our patients. So we're always interested in knowing the factors that maybe influence a patch distribution. And there have been a lot of papers that are published in the past, and they were based on contrast studies where a contrast is injected and we see where the flow of the contrast goes, and that will give us an idea of how the blood will react as well. But very recently, Dr. Callan, who is amongst us today, published this very interesting study where he actually did a CT-guided epidural blood patch and fibrin as well, and actually documented the spread of the actual blood. So not just the contrast, but with the blood. So what did we learn from this very interesting paper is that the spread of the epidural blood that's injected is depending on spinal level. That might make sense. Because the epidural space is larger in the lumbar level compared to the cervical level. So the spread is the biggest in the craniocaudal way at the cervical level. Point 2 is that for each milliliter in volume, the cervical and thoracic patches show a greater spread of the blood compared to the lumbar patch. Now, taking this together, when normalized for patch volume, the spread to volume ratio decreases from cervical to lumbar spine. So therefore, lumbar patching demonstrates less spread as compared to the other levels, and that's probably due to the lumbar curvature, which we discussed already earlier today, and the larger epidural space. So this is important as clinically relevant because most of the non-targeted blood patches will be done in the lumbar level, like I just discussed. So we have to make up for that by injecting as much volume as we can. And this actually confirms data from previous this systematic review as well that shows that the larger epidural blood patches are clinically the better outcomes for our patients. The spread of the blood is also important depending on patch composition. So he found in this paper that actually blood spread more as compared to fibrin. However, that was probably also because the volume was higher. If you would correct for the volume, it was interesting to see that actually fibrin had a bigger spread than blood. Also, the dorsal epidural injections seem to have a larger spread as compared to the anterior epidural space. And like I mentioned before, in the anterior epidural space, there's more structures, there is nerves, and there are more vessels. So that probably explains why dorsally the blood spreads further up and down compared to anteriorly. And lastly, female patients demonstrated significantly greater craniocaudal spread of the blood. And they also noticed a negative correlation between patient height and the spread of the blood. So those are all factors that we have to take into account when planning ahead for epidural blood patch. So the question is, should we do multi-patches? And this is a very interesting study that showed that bi-level or multi-level blood patches tend to have a greater efficiency and a better outcome. However, at the same time, around the same time, this paper came out as well that showed better outcomes as well, but actually also highlighted the higher rate and increased risk of complications when injecting multi-level and high-volume blood patches. So this is still for debate and probably needs further investigations with high-quality studies. What's very important to know, and which we always inform our patients, that it's very likely that the patch needs to be repeated. Okay, so there is around 60% success rate after a first epidural patch, and we see in our clinic as well that the majority of our patients will come back for a repeat. Most importantly for this day, and again, Dr. Carroll will talk about this as well, but what's very important for us physicians is that we do offer epidural blood patches for patients that are not necessarily responding to the International Classification of Headache Disorder definition of spontaneous intracranial hypotension. So that means that patients that are clinically suggestive but have no imaging findings of SIH yet, we should be offering epidural blood patches. This study came out and presented the outcomes of epidural blood patches with patients that presented with orthostatic headaches, but that had negative imaging. So we couldn't find at that time any leak yet. They still got an epidural blood patch, and almost 90% of these patients showed at least 50% improvement of their symptoms 3 months after the blood patch. There was a very recent prospective study by Dr. Carroll on 85 patients. I don't want to explain all the details yet because that's the next talk. But the conclusion of this study was that of these 85 patients, 85% was, according to the definition, negative for SIH, and still responded clinically very well to these epidural blood patches. So that puts us physicians a bit for a dilemma, okay? We have a patient that has symptoms, but not necessarily matches the definition of SIH. So we're basically balancing the risk of patching a patient who ends up being negative for SIH versus a patient that's actually positive, but we don't have any documented findings yet, and we're delaying care by not offering epidural blood patches. We know now that waiting too long with offering blood patches might potentially have a potential devastating outcome for the patient. We know that early blood patching tends to have better outcomes. And we don't necessarily have good data yet as to what the risk actually is of offering a blood patch to patients that end up being negative for hypotension. So that being said, I think it all stands with a good discussion with your patient, informed consent, explaining the pros and cons of this blood patch, what we're balancing in terms of risks, and basically advocating that if the clinical suspicion is very high, that we should go ahead with a non-targeted blood patch. Is the patient going to be helped or recovered right away? No, not necessarily, okay? We know that patients that have SIH have compensatory mechanisms in play where the CSF production has increased to a balance of the loss of the CSF volume. By patching it and putting a large volume of blood in there, the patient not necessarily feels better immediately. At least it takes a week or so before the patient starts getting like a good recovery. In fact, it could potentially be worse. First, because the patient can develop rebound intracranial hypertension, which I'll discuss in a moment. When we talk about post-patch management, so after the epidural blood patch is done, we usually have the patient in our recovery room for around 2 hours in the supine position and then discharge the patient home, where we say to at least stay in a recumbent position for another 24 hours. And again, this is debatable because different centers across US and Canada have different directions, but our approach is usually to stay supine for 24 hours and then, remain low-key for a couple more days. We don't necessarily give DVT prophylaxis unless it's strictly indicated. We manage our expectations. Like we said before, there's a 60% success rate after a first epidural. You can expect gradual improvement over 6 weeks' time and be prepared that we might have to repeat this. It might not necessarily improve immediately. In fact, it can be worse. And you definitely have to avoid these exercises the first 4 to 6 weeks to really give time to the patch to heal and give time to the dura to heal. Like I said, it can get worse the first few days after an epidural blood patch, and patients do often develop some level of rebound hypertension headache, which is actually the opposite of hypotension. So patients will then complain that actually lying flat is particularly painful and feel better when they're sitting upright. They might have also some nausea or blurred vision, and the reason for that is, again, that patients, the body still is trying to find a new balance and might still be in the mode of producing more CSF than actually needed after the patch, and therefore the patient is shifting to a hypertension headache. In the majority of cases, I would say we see that the symptoms are mild. In moderate to severe symptoms, we can start with acetazolamide or topiramate. And we almost never, ever have to do more invasive measurements. Basically, reassurance and some basic treatments pharmacologically is what we need to do. You have to inform the patient of the potential side effects and complications. Usually all patients have back pain the first days after treatment. And there's some severe, rare complications, of course, that you have to inform the patient of. What is more important is that you explain to your patient what are the emergency signs if you have new onset back pain or leg pain, if you experience weakness or incontinence or any fever that might be a risk of infection, please contact the emergency department, and this will call for repeat imaging. So of course, this is a lot of information for the patient. So what our center has worked at is we have created a discharge instruction form that will list all these things that the patient can potentially experience, and of course what the red flags are, and then with some phone numbers and contact numbers to reach out to in case of emergency care need. We usually call the patient the day after or 2 days after the blood patch just to check in and see if everything's okay, and especially also to find out whether the patient is developing rebound hypertension headache. We feel that that's very much appreciated by our patients who go, of course, through a whole myriad of symptoms and anxiety. So we do that, and we basically see them back at 3 to 4 week mark as well after the blood patch to do a new assessment to see if the patient has responded, if there might be any need for a repeat, or if there's no improvement whatsoever, maybe we'll have to go and search further and change our treatment plan. So what we usually do, and this is our lovely team at UHN SIH program, we have complex case rounds where we discuss the most complex cases that maybe have failed epidural blood patching or other reasons, and we come up with the next plan of action. For our center, we have created this flow chart, which is a pathway that helps us in our decision-making process of how to provide best care for our patients. So our take-home messages for today. So epidural blood patches are a crucial low-risk first-line treatment for SIH. Usually we start with a non-targeted blood patch as a first-line treatment, ideally high volume to increase the chance of success. The earlier you do this, the better. In the long run, the outcomes will be for your patient. If there's no response after 2 non-targeted blood patches, we would ask physicians to refer to a specialized center to do more investigations, more invasive radiology interventions, and more targeted treatment. And of course, very important, informed consent with our patient. It is important to explain them all the potential risks and benefits. And a close follow-up, peri-operative around the blood patch, and of course in the weeks and months to follow. And that concludes my presentation. Thank you.